This program is a presentation of UCTV for educational and non-commercial use only.
Good afternoon, everybody. How are you? Well, it's 2:20 p.m. and Friday, so I know what it means, right? Okay. All right, let's start. And again, my name is Eunmi Cho. Come on in. We have a lot of seats empty here front. Okay, I have a. Right, I work this place, Sacramento State University, in special education departments. Let's see, let's check who we are all together. Any parents? Yay! I'm a parent too. And how about service providers in education field? Teachers, psychologists, thank you, thank you. And what about students? No students, okay. What about service providers in medical field? Yes, yes, okay. Again, thank you so much for coming to, oh yes, I see my students and my former colleague, and I studied from, classroom teaching as a special education teacher long time, and then I've been here 9 years at Sac State. Okay, what we're gonna talk about today is the special children who are learning English as their second or third language, but happen to have disabilities, especially speech and language impairment. So we're gonna talk about research, especially Dr. Gutierrez Clinton's research. We're gonna focus on that, and so that we can also address the needs of culturally responsive practices in education and also medical fields. That's what we're going to talk about with specific 3 objectives. Before we get there though, I have to say that none of us have any interest in any products we are talking about today, okay? So I have to disclosure. Yes, 3 objectives. By the time we finish 15 minutes of presentation, I want all of you be able to describe some of the characteristics of children with language disorders, also to differentiate typical from atypical language acquisition in second language acquisition, and also I'd like to ask you to talk about it, take it in with you some strategies, and then implement, okay? So our focus is we're gonna address issues related to the identification of language impairment in English language learners, parents of typical and atypical bilingual acquisition, and individual differences in language learning. I said that bilingual children with language disorders, who are they? Dr. Gutierrez is gonna talk about more later on, her part. So I'm gonna just show you that second language dominant with limited English proficient children And the other hand, English dominant with limited second language proficient children or both fluent children. Okay, so bilingual children. Now I'm going to talk about California. Yes, California is very abundant and beautiful state. It's beautiful because we have so much diversity here, right? Do you agree with me? Yes. And I'm going to show you a number. However, if you were here last year with me, you already know the answer. So don't answer, okay? All right. What is 39%? Why is it a significant number in California? Just guess. Any brave volunteers? Just shout at me. Percentage of? Caucasians. You mean white? Yeah, okay. All right, yes? Yeah, okay. 39%, based on the report done by children now, 39% is the percentage of children in California public preschool program, 3, 4, 5 years old, who are English language learners. And what are the languages we see around our lives in California? Spanish? Throughout California, just Russian, Vietnamese. All right, let's look at it. Okay, Spanish, almost 85%, followed by Vietnamese, Hmong, and Cantonese, Filipino, and Korean. These are the main languages in California. Let's focus on the languages I chose. It's 6 languages based on the CDE data quest recent. I pulled out this information recently. Spanish is 85.1, Vietnamese 2.2, Filipino 1.4, followed by Cantonese, Hmong, and Korean. These are the 6 dominant languages as a second language in California. Where are we today? Now? Sacramento, right, Sacramento. Let's look at the Sacramento. Spanish is half, Hmong, and Russian, Vietnamese, and then, other languages. If you work in this area, that means a lot to you, right? All right, okay. Let's look at the young children because that's where we started, right? I chose 4 different ethnic groups. Asian, followed by next to Hispanic group, and African American group, and white. And then also I chose 4 different disability categories. Mental retardation is the first one. Speech and language impairment is second. Specific learning disability is the third, and autism. What does the bar graph tell you?
There's a proportionate number of children who are Spanish who identify as speech language disorders.
Right? Yes?
Those are absolute numbers? The bar graph is of absolute numbers of children diagnosed?
Yes.
Okay, so
Yeah.
it's also probably
Yeah.
a lot affected by population size.
Right. So the purpose of this slide is to show you the incidence of disabilities by ethnicity. But I want you to note the disproportionate numbers of Hispanic and students identified with speech and language impairments, like you said. However, I also want you to pay attention to understand that the numbers indicate that there are more Latinos and Spanish-speaking children in California. It was 85.1% in California, okay? So it's not just because of misdiagnosis, okay?
If you're comparing it to the the number of
Right.
white children who I assume are monolingual English-speaking children. It's clearly
It is, yes, yes. So, this is the data, again, by CDE Data Quest, recent one. And that's why we have the most prevalent category is, we looked at it, is speech and language impairment. I told you this is for the preschool age children. What does it mean? Preschool children with SLI, most prevalent disabilities, speech and language impairment. I do not have a research data. Maybe, Dr. Gutierrez later on tell you. However, I noticed, because I teach K through 12 in special education, I see those children in preschool age with that diagnosis, SLI, to come to our program because I teach children with learning disabilities, specific learning disabilities. So I see most of them coming to that category later on, add to SLI or re-diagnosed later on, like usually third and fourth grades. Okay, so when we assess our children, we really, really need to make sure that it's not primarily the result of environmental, cultural, or economic disadvantage of these children. Consequently, we, all of us, are responsible to make sure to assure that young children are assessed with their, what? Yes, as much as possible, primary language, okay? Well, it's from the, another researcher and faculty member at Vanderbilt University, Dr. M.I.N., kind of, described two different, groups of children. Language difference, we're talking about the second language learners, and language disorder, children with speech and language impairment. I raised two children. They are trilinguals now, fluent Spanish and Korean and English. And when my son, Jason, was growing up, he had a different pronunciation, of course, because we are immigrant to this country. So his schooling was not easy in the beginning. He needed to catch up contents as well as the English at the same time, right? As an English learner. However, he was able to function fine in Korean American community at church in Korean language. However, it takes some time. His friend, Tommy, from same church, he has language impairment from the beginning when he was 3. He had difficulties of pronouncing and producing and understanding language, both languages, primary and English also. And then he was having a difficult time to figure out what the body language means to him, even in, again, Korean language. He still has a problem. However, when we began intervening him and give him a, intervention in primary language, we saw tremendous progress in his, speech. So Koreans are different from, it's the alphabetic system. However, we don't have our, articles like the and 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 we don't differentiate the plural and singular, and the, also structure is different. We don't say, a subject and then, verb and object. We don't do that. It's a different structure. So second language learners who are speaking Korean are having difficult time in the beginning of their school life because of the difference between, English and Korean. Same as other languages. So as a teacher, as a practitioner, we have to be aware of, you don't have to be fluent or, linguist for all the languages we have in our classroom. However, we need to be aware of, okay? So from now on, Dr. Gutierrez is going to talk about her current research. Yeah.
One of the, before we start, I wanted to give you a little bit more of context about who we are talking about. as one of your comments suggested, there may be an overrepresentation of children with typical language development who are just second language learners. In caseloads, they may be over-referred because of the potential concern about language impairments. But what we see is that in many cases, children are not referred. It depends at what age that assessment is done and how it's done. In my research with preschool children, for example, what we see is that children are not, even if the parents are concerned and the teachers may be concerned, we find that many children that should have an IEP do not have it. Because clinicians typically wait, because they may not be a clinician with the bilingual skills and the training to be able to do these assessments. So what we see, because we are engaged in recruiting children for our research, our intervention studies, and our longitudinal studies, is that many children who are actually meeting criteria as having a language disability are not getting services. So, and I think that one of the problems, in addition to the lack of assessment tools and the lack of training of practitioners to be able to identify these kids, is that people and teachers, educators in general, tend to assume that bilingualism, that children who are bilingual take longer to learn. Okay, that we just need to wait a little more than if we were assessing children who are only learning one language. Okay, when we are assessing children who are monolingual, we know that by a certain age and by a certain point in development, children who are not producing, let's say, 50 words at age 24 months should be looked at, right? Those children, if they don't combine words, for example, at 24 months, they may have a language delay, right? So we do a full assessment to see if they actually do. And we know that those developmental milestones that we know about based on the child language development in monolingual children exist and are confirmed across languages in the world. So it's not that learning Chinese or learning Korean is going to take longer than learning English, right? Children by age 24 months should all be able to combine words and or say at least have 50 words in their lexicon. So the idea of waiting to do an assessment because children may take longer really is not supported by the research that we have when we look at children longitudinally. One of the other problems that we have in doing a good assessment or in being able to get an accurate assessment of children who are learning two languages and who may have a language impairment is the idea that children may, we may, if they're speaking both languages, that we can actually assess them in one, and if they score low in one language, they may, have a language disorder. So if we find an overrepresentation of children with language impairments, in second language learners or in dual language learners, it may be because of that assumption that if children learn two languages from birth, those two languages are equally, growing equally, at the same level. They're evenly developed whenever we decide to test them. And that's a false assumption. What we know based on monolingual and bilingual longitudinal research is that the two languages are not learned at the same time with the same rate of growth. Okay, so there are individual differences within children in the rates of growth of each language. Okay, so at one point, one language may be more advanced than the other, and then you look a little bit later, and that's not the best language for that child. It may be the other one. Okay, the first language. So the idea that the home language is always going to be the dominant language is not corroborated by the research that we have. And what we know is that language dominance is not stable and changes over time, okay? So I'm throwing a lot of concepts here. I had a couple of graphs that I don't know where they are in this file that show that the two languages are not balanced. And we see this from birth all the way to adulthood and in older people, okay? Depending on the measures that we test the children or the adults on. And this is, why is this? Because the two languages are learned quite independently, okay? Even though we are talking about the same subject, the same child, the same person, we do not have two monolingual persons in one human being, okay? So we have the same level of range of individual difference that we find in monolinguals in bilinguals, okay? So we can go over this with more examples later, and you can ask me questions anytime. So the idea is that even in children who start with learning the two languages from birth, very, very early, when they go to a daycare, they may be exposed to English, and they may be exposed to both languages. They may learn more words in one language, some words in one language and some words in the other. And that's why when we do assessments, we always recommend to use conceptual scoring, to give credit to what the child knows in whatever language the child responds. Okay, let's see if I can go back to this. Okay, so when we are talking about children with language disorders, we are talking about children who have significant difficulties in the two languages. So within this population, and taking into account that there are these great individual differences in acquisition, okay, of each one of the two languages, what we use to actually determine, establish if a child has a true language impairment and not just a second language acquisition issue, is to see, is to have an indication that there is a significant difficulty in the two languages, so that the child is actually below age expectations in each language. And one of the challenges is to determine what kinds of domains to use to actually look at language development or language skills in each one of the two languages. We don't have tools for all the first languages that we have represented in the state or in our sites, in our settings. And so we use a lot of, if we don't have those standardized tests, we rely a lot on clinical observation, on parent report, on teacher observation, and on spontaneous language samples, okay? Spontaneous language samples elicited in conversation or in storytelling, using different play activities. So that we use pretty much criterion reference measures. So we use the research that we have across different languages to see what will be specific indicators that will give us information about the acquisition, the status of each one of each language, and if we find evidence of delay or a significant delay in each one of the languages, then we may be more confident that the child may have a language disorder. So when we are looking again at the language domains, we focus primarily on the area of grammatical development and semantic development. And I can tell you that there are very specific features that we can use to identify language impairment in English. We don't have to test for everything when we are looking at 4 and 5-year-olds. Children who have language impairments at age 4.5, 5, have significant difficulties with verb tense in English. So it's very easy to do an assessment even if we just use spontaneous language samples. When we look at other languages, other first languages, we have also research that shows what those grammatical indicators may be. And in the case of Spanish, we know that children have difficulty producing articles in Spanish and pronouns. Children with language disorders tend to omit them at these early ages. One aspect that is critical and that most clinicians don't pay much attention to is vocabulary. Vocabulary is one of the critical precursors of reading comprehension. So even if children are able to decode because they have sufficient phonological development and phonological awareness when they're in kindergarten and then they can start reading in first grade, they may have significant reading problems when they have to read for comprehension purposes. So because vocabulary is so important, we have a large number of second language learners who may be lagging behind their peers by 2 grade levels because in reading, because of the vocabulary domain, okay? So even if children may have a limited, even if after an assessment, these children are, and with some intervention, are capable of showing good grammatical skills, we need to keep in mind that vocabulary needs to be reinforced and continue to be stimulated for these children to not to be diagnosed as having a learning disability later on because of their reading comprehension problems. So we are using a lot of criterion reference measures. And we are, in order to make an appropriate diagnosis, we must find evidence that both languages are significantly affected. When we are looking at children who are second language learners, as I mentioned before, the 2 languages are not learned statically. There is an interaction between how much the child's aptitude and ability to learn, okay, as a learner, and the educational opportunities that are available to the child in the language environment, being that the home or the classroom or the daycare. And what we see is that as children learn a second language, if the first language, the home language, does not continue to be stimulated, children may start showing difficulty in that, more difficulty in that home language. So the skills in the home language may go down as opposed to stay the same, okay? And that's one of the problems that we have in assessment. We want to test both languages. Clinicians sometimes think, okay, if I just test in the home language, since that will be the better language, I can get the assessment done that way without testing the kid in the second language, because I know the second language is not going to be that good because the child is still learning the second language. But what we see is that even the first language, the home language, may deteriorate unless it's sufficiently stimulated at home through literacy activities or in the classroom. And we know that in many classrooms, the teachers are not doing that because the language of instruction is English. Okay, so I would like to take a minute to go over some of the myths and some of the concerns that clinicians and educators and parents in general have and that always ask us about. Should we, is it a good idea to raise my child bilingual if he has or she has a language disorder? Am I going to delay acquisition if I continue using Spanish at home? These are all valid questions. Is it a good idea to suppress one of the languages? Am I going to help accelerate development if I suppress one of the languages? Or is there not going to be a difference? So one of the things that the research that I've done and other colleagues have done has shown that when we compared monolingual children with language impairments matched by age and by measures and by language, we don't see that the children with language, the bilingual children with language impairments are more severe than their monolingual children with language impairments. Okay? We've done studies with Spanish-speaking kids with very little minimal English, and compare those to children who are fluent in both, but also with an impairment, and they perform the same on the language, on the best language of the assessment. Yes?
Have you studied households where one parent speaks one language and the other parent speaks the other language? Because that's more challenging. Because like if one side is the immigrant in the family, you don't have the whole family, like you're saying, they go to the Korean church. But what if you don't go to the Korean church? The wife came from Korea all by herself. The husband is American. Everything else is English speaking. So how is this mother going to maintain that cultural and the language exposure all by herself?
Normally,
a child that already has the language.
Nobody maintains a culture by yourself. That's how it is. I mean, it doesn't happen.
My curiosity is if you have separate cohorts or whatever you call in your study, that just like one, it's just a partial, it's a bilingual household.
Yes.
Besides being a...
Yes. You know, one of the hardest things for doing research with bilingual children, with young bilingual children, is when both languages are spoken at home, is to be able to get a good estimate of input in each one of the two languages. Because parents, you know, they must have either a third language that they speak to the child, or one of the two. You know, if both parents don't share those two languages, you know, the parent that spends more time with the kid maybe is the language that the kid is more exposed to. But I mean, then what we end up doing to be able to get at that estimate of input is to actually count the number of hours the child is interacting with whom, doing what, how many days a week. And so we get an amount of input that way. And that works when children are very young. But when children start going to daycare or to preschool, it's very difficult to be able to get an estimate of input. And children are getting input from their peers. So what stimulates the language is not necessarily their interaction with an adult that speaks it. So we can, let's see, I want to go over some other myths that, you know, and assumptions that people make when they make recommendations, when pediatricians make recommendations to parents and teachers, or when teachers make recommendations to parents. One indicator that they use to say, oh, these children are getting confused when they're speaking, these children are getting confused is if there is evidence of code switching. So if you see children who are mixing the two languages within a sentence, typically that is taken or interpreted as, oh, these children they can't speak either language, they're mixing them, okay? And so I want to just reiterate that there is a whole world out there of research in code switching within typical bilinguals, okay, across the lifespan, that shows that code switching is a typical behavior that, of course, only bilinguals can do, because you have to actually know very well the two languages to mix them, right? So we did a study that was just published in the International Journal of Bilingualism a couple of months ago, or maybe a month ago, where we compared children with language impairments, bilingual, and children who were bilingual that didn't have language impairments. They were all Latino kids, all from 4 to 6 years of age. And we didn't find that the code switches that they made were different, more weird, more atypical than their typical peers, okay? So there is nothing about code switching that should be taken as an indication of disordered speech. And that is very important because many teachers and clinicians and supervisors of clinicians tend to say, oh, don't mix the languages because that's not going to help the child learn the languages. Well, you know what? Bilingual communities mix the two languages with a very high level of proficiency, not because they have a language disorder, because that's how they talk. It's a discourse strategy. It's a high-level language skill. What we typically do as a supervisor, a clinical supervisor, is, if the child code switches, you code switch. You go with the child. You follow the child's lead. Don't try to correct the child because that's something that the parents are doing too, and many other adults. In terms of then the idea that exposure to bilingual input would delay acquisition, based on the longitudinal developmental research that we have available, we don't have evidence that bilingual children are going to be more delayed or more severe. And so based on that, we don't have any evidence to recommend to suppress one of the languages, okay? If bilinguals are not developing slower than monolinguals, we shouldn't tell people that they should be monolingual, right? Bilingualism is not going to slow the kids down. And I'm not saying that bilingual education or bilingualism is going to help you become smarter. I'm not saying that. Although some researchers are doing research to show that there is a cognitive advantage in certain processing measures, not even nonverbal ones, but I'm not going there. I'm just saying, if we don't have evidence that bilinguals are slower or more delayed or take longer to acquire a language or languages than monolinguals, then we shouldn't make the recommendation to suppress the home language or any language. Okay, we shouldn't even question what language to choose for intervention purposes. Okay, so we have all these options, right? We have the option of either intervening in English only or in the home language or in both. And we have very limited research, of course, on the effectiveness of a bilingual versus a monolingual approach in intervention. Probably we have been the first ones in the country that have done direct research looking at children with language impairments using a bilingual versus an English-only approach for delivering those interventions. And it was a grant by the Institute of Education Sciences that we are completing right now. The picture is a mixed picture. It's not black or white. So I'll just give you an example in a second. But the idea is that we have very limited research on the efficacy of either using a bilingual or a monolingual approach to intervention. And the goal here when we are talking about intervention efficacy is we are looking for a benefit, right? We are looking for increased gains, greater gains using one approach versus the other. If we don't find that, okay, it doesn't make a difference, right? And that's one of the things that we were interested in looking at with our intervention research. Okay, so we went over this, the idea that many clinicians and parents, when they have a child with a language impairment, they feel that maybe it will be too hard for that child to get a bilingual intervention. And many times they would say, oh, it's okay to teach your child two languages or to keep a second language at home if your child doesn't have a language impairment, but if he does or she does, then it's not a good idea, and we don't have evidence to make that recommendation. Children who are impaired and learning two languages do not take longer than children who are impaired and are learning only one. We don't find that they make more errors than monolingual children with language impairments in each one of the languages. Okay, so they're not more severe because they're bilingual. And we don't find that children who are receiving a bilingual intervention, their intervention in the two languages are not learning English as much. And I'll show you that in a second. So if you want some references when you make recommendations or when you want to explain to parents or to pediatricians or to others or teachers that there are no differences, I listed some of the references at the end. The research by Pearson and Oller and Genesee are all conclusive in showing that if you combine the vocabulary scores in each language, children who are bilingual develop at the same rate and to the same level of, to the same extent as children who are monolingual. Okay, so you have the same individual variation that within languages that I mentioned to you before. When we have some very few studies looking at the effects of bilingual intervention approach on language development. In general, everything that people has done in the area of bilingualism is in regular bilingual education, is looking at academic achievement outcomes. Here, our focus, because our focus is on language disabilities, we are interested in looking at what is the language intervention approach that may be most effective when we are helping children who have a language disability, a language learning disability or a language impairment. One of the research, previous research has shown that children who are typical benefit from a bilingual intervention, that the home language can only grows if it continues to be stimulated, and in children who are typical. So that in order to be able to continue developing the home language, the children who are typical need a bilingual approach in intervention or in education. What we found in our project with language impairment, without children with language impairment, specific language impairment, is that we compared the outcomes for the home language when the kids received the intervention in the two languages versus only in English. And what we found was that there was the kids that got the intervention only in English didn't show the same level of growth in the home language as the children who got the intervention in both languages. We need to differentiate grammatical outcomes from vocabulary outcomes. We know that if vocabulary does not continue to be stimulated, these children, if they're tested with the TVIP, the picture vocabulary test for Spanish, they are going to score worse, lower over time. They don't grow, they go down. Okay, because the norms are based on monolinguals who are getting literacy instruction, educational instruction in Spanish. So that language, that vocabulary language, continues to be growing. Okay, I think we talked about this. One thing that we found in terms of the outcomes of this treatment study that we are finishing right now as we speak, is that we were so amazed to see that the children with language impairments that were receiving these interventions either in both languages or in only one, we had 4 conditions. We had 2 control interventions in 2 languages or in 1 or in English only, and then the experimental language intervention in the 2 languages or only in English. And we had an oral language component and a vocabulary component that we were focusing on in small groups of 4 kids with language impairments within the regular preschool. They were all 4-year-olds, 4 times a week, 45 minutes a day. That was very intensive. What we found was that our children with language impairments made more growth, showed a higher rate of growth in English than the typical children in their preschool classrooms. So just by doing this intense, the children that were just exposed to whatever they were getting in the classroom were not learning as much English as our kids who had a language learning disability. So, the point here is that these children can still learn English if we provide them with the appropriate environment, learning environment. That if they're just exposed to whatever the teachers are giving them in the classroom, probably they're not going to make much progress. But that because they're bilingual, that even if they are bilingual, and even with a language impairment, these kids are capable of learning the 2 languages if both are being stimulated. One aspect, one more thing I wanted to say before we get into the discussion. I think we don't have much time. She has to talk about strategies. We didn't find that children with language impairments were more susceptible to language interference. Okay? They didn't make more errors of transfer. This is important because this is another assumption that I hear a lot, that the Spanish is going to affect their English, and they're going to get confused. They're going to make more errors because they're going to transfer from Spanish. We didn't find that. We compared the groups, and they didn't make more errors than the children that, than typical children learning English as a second language. Okay, they didn't make more omissions of the subjects. They didn't make more second language influenced errors. Okay. It's important that we focus not only on grammar, but also on vocabulary, as I mentioned before, and that in the assessments that we do, you must consider the acquisition of the 2 languages, the possibility that one language is still being learned and the other one may be lost, or maybe in the process of attrition. Okay. I want to show you one more slide here because it's critical that we look at the quality. I think those graphs are not here. Okay. One thing that I found is that the children who were, as I mentioned before, we compare different sites. We compare children who were in Head Start and in state-funded preschools to look at typical children, okay? Typical children in both different sites. The kids that were in one site that were not getting sufficient, a high level of instructional experience, that were not, the quality of the instruction was not focused and intensive, didn't make much growth. So when we do an assessment, we have to consider what are the classroom variables. What is what these children are exposed to? Because their growth was so low that, because we know how to identify children with language impairments, we know that they were not impaired, but their scores were extremely low compared to their typical peers that were in a different instructional environment. And these were all typical children. And the differences were greater for vocabulary than for oral language and than for English grammar. So it's important that we look at the contexts of learning when we do our assessments also.
Okay, in 5 minutes, let me see what I can do in terms of strategy part. This is the 3rd objective we talked about that we want to get, okay? Well, culturally responsive practices and strategies, we probably heard a lot, but because of time, what I'm gonna do now, I'm gonna have you look at it and pay attention on like a time and space and organizational skills and also communication. And especially when you are medical doctors, and you probably were aware of the different cultural practices your patient bring to your office, in terms of the health practices and what they believe in, what they not. And we need to be familiar with those practices. However, let's talk about the appointment. When I came here, I was 29, and as a mom, I have to take my children whenever they are sick to get to see them, the doctors, right? First thing, I noticed that I have to make an appointment to see the doctor. Well, it didn't make sense to me at all as a young mom that my kids are sick. Why do I need to make an appointment to see the doctor? I still don't understand, but I have to make an appointment. Many countries, we don't make an appointment. It's an emergency. It's child and I am sick. I have to see the doctor, that's it. Probably you never thought about it. But that's the first thing I noticed that, okay? And also, many Asians, in Asian culture, the assertiveness and individualistic views are very considered crude and poorly socialized. Which means, let's look at the, here, the interdependence versus independence, groupism, individualism. If you're an educator in your classroom, you will have students who prefer to work as a collaborator in a small group setting than working as individual projects. Yes, it's a personality. However, if you keep thinking deeper level, it's from community, it's from their household. That's how they practice. The groupism is very important in many Mexican American and especially the Asian cultures. And so cooperation and interdependence are very important values within the culture. So in classroom, we need to be, pay attention on that. And however, Western medicine and education tend to value autonomy and independence. On the other hand, patients in parents from other countries, especially Asian countries and Hispanic culture background, they often value the family over their individual decision. So just wait, I will decide what I'm going to do for the physical exams. I need to talk with my family first. I think that it's better to have you wait. Have them to go back to discuss about the health issues and come back to make another further appointment for the exams, because that's how they practice. And expectations when children interact with the adult in terms of the communication. Well, families have often different forms of the conversation based on the age and social status. First thing, most Asians, I am making generalization here. However, most Asians will check your age first. When you have a first acquaintance, I was going to ask when I met Dr. Gutierrez, how old are you? Because I need to set up my status. If she's older, I need to use more honorific way of the language, and my gesture, facial expression, and my body, gestures all different based on the age and hierarchy of the social status also. Implication as a medical doctor and also a classroom teacher, you have to be make sure what's the hierarchy of their culture. Who is a decision maker? Father or mother? And grandparents. And first name, yes, it's friendly. However, in many Asian cultures, you don't call me Eunmi in campus. Professor Joe or Dr. Joe is my proper, or Mrs. Joe, at least. So first name, what's the best strategy? Ask your parents, ask your patients, how would you, prefer to be called? Or is it okay to use the teacher's first name? And also, how are children expected to talk to adults in your household? Because while I was growing up in Korea, I was not able to, not expect to, ask questions whenever we eat. And I cannot even sit with my grandparents. We have a three different, tables for dinner table, grandparents and my parents, and then I, children, and the woman also verse. So you have to just ask your parents and patients about their practice at home, because some parents and patients still practice their traditional culture. Okay, if you are service provider, what do you think about this quote? It's from the book by M.I.N., The Spirit Catches You and You Fall Down. It's a story of a Hmong girl, and her American doctors, and the collision of two cultures, Hmong culture and mainstream culture. Okay, what we're gonna do, I'm gonna have you think about just 1 minute the quote from the book. Okay, if you get the idea, I think you met your objectives to be here. Okay, we thought that we're gonna give you some time to answer, and we will be here about 5 more minutes. Our session, based on the time, we're already done, but we are punctual, right? 20. Yes, miracle. However, 5 minutes, we're gonna stay. She needs to catch the flight, so yeah. If you have any question, individually, I will be answering probably one question, okay? But if you need to go, you may go. Thank you so much, and see you next year. Yay! Okay. Yeah, I'll repeat the question. Yes? Yes, ask.
I think that my biggest conflict here is that a lot of this information is I understand and I've known and I've learned that you do need to look at children and not go biculturally or bilingually when you're assessing. But the reality is that not being bilingual myself, I'm still expected to assess these children.
Right.
And to do my best to make a decision about whether they're bilingual or not. And I feel like I don't have half the story. Are there any strategies for aside from parent interviews, for bilingual assessors to help them better differentiate typically developing bilingual children versus children with language no. We don't know.
We don't know. I think this is a research that we need. We can't really make a language diagnosis by looking only at the child's second language. So there's no way that we can do the assessment correctly or precisely or accurately unless we look at both languages. And if we don't know the home language, it's a problem, yes. So that's why we rely on parent reports. That's why I ask parents to tape record, write, and we use paraprofessionals that would transcribe what the child said and tell us exactly what the adult form should have been, what the child actually said, and we do a contrastive analysis and see, okay, would this be correct? And so, yeah, we use criterion reference measures. We don't have anything else when we don't know the language of a family. We need to use them as informants. And clinic and observations.
Observation, yeah.
And RTI, response to intervention, of course.
The UC Davis M.I.N.D Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.